Hi everyone, such an honor to be here. My name is Katherine Kunkel. I am the newest member of the Interventional group at Piedmont, Atlanta. These are my conflicts of interest, and I will be discussing the Impella CP device during my talk today. So we've all taken care of this patient, right? 53-year-old comes in, hypertension, 2 hours of chest pain, comes to the ED, elevated troponin, anterior ST elevations, loaded with the right meds, comes to the cath lab in the right time, gets the right intervention. Everyone's doing high fives. We did everything right? The patient leaves the hospital a couple days later, and this is what their heart looks like, right? An ejection fraction of 20%, akinesis in the LED territory, a dyskinetic apex. 3 months later, on all the right medications, following with our heart failure colleagues, EF of 40%, and just essentially a dead LED territory. And we all take care of this patient, right? This is incredibly frustrating because we did all of the right things here. But despite doing that, our patient has not had a great outcome. And so how do we think about this? How do we think about this in 2022? What can we do better for our patient? And so this takes us back to how we've thought about caring for patients with acute MI for a long time. So, this idea of oxygen demand versus supply, proposed in the 1970s by Bonewald and colleagues, and really has been the foundational model for our thinking. And for the last 50 years, we have focused on myocardial oxygen supply, right? And this is no surprise to anyone in this room. This is how we have saved lives for the last 50 years. We know that a lot of seminal work in the 90s and 2000s showed us that if we get in there in less than 90 minutes, we save lives. And huge public health pushes to reduce door-to-balloon times over the years. And this is how we live our lives as interventional cardiologists, right? This is how we all made the decision to get up in the middle of the night, come in and save someone's life, right? But can we do better? And so Dan Menese's group, the University of Michigan, looked at over 100,000 Medicare beneficiaries with STEMI. And over the years, as door-to-balloon time has gotten faster and faster, we have seen no improvements in mortality, right? And if we look at high-risk subgroups, specifically those bad proximal LED STEMIs, if we get faster, they don't get any better. And as we're doing this, we're seeing what we all know in our clinical practices, massive rises in the number of patients with ischemic cardiomyopathy and ischemic heart disease in our clinics, right? And when we look at kind of a natural history of what happens, this is the Circus trial, which was a negative study, but it gives us a good idea of what happens to these anterior STEMIs over time. And in 1 year in this trial, 60% of patients died, had a heart failure admission, or had worsening LV function. 60%. And again, these are patients in clinical trials where we're doing all the right thing. And Greg Stone did a great job putting together 10 different randomized trials looking at different revascularization strategies. But the take home here was that infarct size drives heart failure, hospitalization, and death. And they were able to nicely stratify by the size of the infarction what happens to patients. And we know that for every 5% increase in size, there is a 20% increase in heart failure, hospitalization, and death at 1 year. These are tremendously large numbers. And so then I think this should lead everyone in this room to this question: can we do better, right? Can we do better for our patients? Because unfortunately, at this point in time, the low-hanging fruit is now gone. And so a lot of different trials and investigators over the years have tried different therapies to reduce infarction size. And the graveyard of different therapies and interventions that have made it to phase 2 and phase 3 trials is big. I kept having to make my gravestone smaller and my writing smaller to fit in kind of all of the things that have not worked in this field. And so now kind of with all of this, the focus has moved toward, now that we've taken the low-hanging fruit off of the table, what can we do to reduce myocardial oxygen demand and attack this problem in a different way? And so this is where the idea of LV unloading comes in. And so we have our acute coronary occlusion, and we see this in our practice. We reperfuse the coronary, we increase the oxygen supply, we have this big infarct zone that ultimately necroses and dies, and we get ischemic cardiomyopathy. But maybe there's another way. Maybe the other way is LV unloading, where we can now have cardioprotective signaling, reduced oxygen demand, and maybe we can salvage some of this myocardium. And this is not a new idea, right? So people have been studying this idea of LV unloading to reduce myocardial demand for over 50 years. But you will notice that all of these studies are in dogs, pigs, and monkeys, and some sheep. So what have we been able to do in people, right? And so we've learned a lot from the adjacent field of cardiogenic shock. And so over the last 15 years, there's been an increasing use of transvalvular unloading in shock. And what we've learned of meta-analysis of over 700 AMI cardiogenic shock patients is that if we compare patients who get unloaded first before PCI to those who have PCI first and then unloaded after, there's consistently a signal of reduced mortality when you place the Impella first. And so this has been studied in humans, first done in the CRISP AMI trial, and this was with balloon pump. So unfortunately, this showed no significant benefit. 340 patients with anterior STEMIs, no cardiogenic shock, randomized to PCI versus balloon pump insertion and then immediate PCI. And we saw no difference in scar size, no difference in outcomes, either safety or beneficial outcomes with balloon pump to reducing infarct size. So this kind of sent the investigators who really think about the unloading space back to the drawing board and really started thinking about and focusing on this idea of transvalvular unloading. And so there have been a tremendous amount of preclinical work that involves a lot of molecules that I don't know the names of, but there have been really two pathways that have panned out at the end of the day. And so first is this SDF1 alpha pathway. And so the general idea is when something bad is happening to a myocyte, for reasons we don't fully understand, you get increased matrix metalloproteases, which destroy SDF1 alpha. Once it's destroyed, you activate this risk pathway, and that ultimately leads to apoptosis and increased infarct size. But again, for reasons we don't fully understand yet, in hearts where you unload them first, you preserve SDF1 alpha. And so it's able to bind to CXCR4 and then trigger this whole pathway that sends molecular messages that says, preserves mitochondria, preserves myocyte function, and reduces your infarct size. And this was very elegantly shown from Naveen Kapoor's lab. And I won't go into too many details here, and this is the only Western blot we'll look at today, I hope. But you can see here in the group that was unloaded for 30 minutes before reperfusion, you see a lot of this SDF1 alpha is hanging around, and that's a good molecule. And then as we look at the hearts that were unloaded, again, we're seeing higher levels of CXCR4. And again, this is a good molecule. This is promoting cells to continue living. And when we actually look at the cells under electron microscopy, in the middle, that's what we do right now, right? So the middle is people who just got immediate PCI, and those are exploded mitochondria. In people who got unloaded, which is on the right, you see cell integrity. And so I want to be on the right. And so this is how that trial worked, and this is where we saw the benefit. And this is the idea of putting an Impella, standing there for 30 minutes, looking at an occluded LAD, and then intervening. And this group consistently has shown to do the best. More work in this area has also shown the importance of myocyte metabolism, and another pathway that seems to be really important is related to mitochondrial metabolism. And so again, related to the citric acid cycle and preservation of mitochondrial complex 1. And again, we don't fully understand the mechanism, but somehow this seems to be very important and is activated by unloading. And so there are a lot of different ways that unloading can help us, at least theoretically. It reduces our oxygen consumption. It activates these signaling pathways that seem to keep our myocytes alive. It increases our microvascular perfusion in the infarct zone. And then there are other clinical benefits that are obvious to us taking care of patients. Hemodynamic stabilization during arrhythmias, bridging through myocardial stunning. And so this leads to probably the most important trial that's been done in this space thus far, which is the STEMI DTU meaning door to unload, pilot trial. And so this was 50 patients in a multi-center trial that was randomized to either Impella and then immediate PCI. And again, these are stable LAD STEMIs. These are not cardiogenic shock patients. Versus, again, this idea of you put in an Impella, you stand there for 30 very long minutes, twiddling your thumbs, and then you intervene on the LAD. And they looked at MACE at 30 days and infarction size. And what we learned is that this is a feasible strategy. This added about 15 minutes to the case in terms of getting things rolling. And we did see, as predicted, increased door-to-balloon times in the patients where you were standing there looking at an occluded LAD for 30 minutes before intervening. But you'll see here all those p-values I've circled are about 1, which is a good thing. That shows us that this strategy is safe. And while we didn't meet any beneficial trials, this is a feasibility study. And so the big pivotal trial is ongoing. So that STEMI DTU pivotal started enrolling in 2019. Same patient population, 1 to 6 hours of chest pain, hemodynamically stable anterior STEMIs who are being randomized as we speak to standard of care, primary PCI, versus primary unloading, 30 minutes of standing still, and then delayed PCI. And so this is projected to finish enrolling in 23, and we're hopeful to have results by 2027. What are some important challenges with a DTU strategy? So I think probably everyone who's been working in a cath lab or a CCU is really thinking about vascular access, right? This is a major issue. And so we know that we've been able to get better at large bore vascular access. And in contemporary elective patients like TAVR and EVAR, we're down to 1 to 2% complications. But that is not true when you look at patients who have emergent large bore access. And a lot of different series have looked at this, and the lowest you'll find is 10%, the highest you'll find is 20%. So we still have a problem with vascular access complications and urgent large bore access. And so we know, it should be obvious, a DTU strategy is gonna have increased bleeding risk. Will the benefits of unloading be enough to offset this? Because we know bleeding is bad in these patients. It's also, I think, going to be a challenge to identify who are the right patients in clinical practice. You know, all these clinical trial settings, they're looking at patients who are present within 6 hours of presentation. That's not real life, right? So early presenters we think will benefit from infarct salvage, but late presenters, probably not so much. Maybe there's a role for hemodynamic support during clinical stabilization. Hard to say. So at the end of the day, DTU versus DTB, this would be a massive paradigm shift for us, right? This would change the way we practice medicine. But we've done that, right? Interventional cardiology is not that old of a field. And we've had, and many of us in this room have lived through massive paradigm changes. We've gone from balloons to stents, lytics to someone convincing all of us to get up at 3 o'clock in the morning and put a stent in someone having a heart attack. You know, we've transitioned from radial to femoral, and I would argue now we're in the middle of a transition of angiogram to physiology and imaging. So maybe DTB to DTU is the next transition. So I would say, you know, right now, the conclusion for answering the question that I was asked to answer today, you know, a sick patient in their 60s, DTB versus DTU, today DTB is king. You know, and I don't think we have the data to argue about that in 2022. But maybe in 2023, not so much. You know, we have plateaued with DTB. And we know that big infarcts are bad for our patients and they're driving problems for the rest of their lives. And I do not like leaving a 50-year-old with an EF of 40% and a dyskinetic apex. And I think if there's something that I can do at 3 o'clock in the morning, that is worth 20 extra minutes of my time to change the course of that person's life. So stay tuned. Thank you.